This video is a healthcare case study of wrong site surgeries. We begin with a could cause map, or a proactive map that will address the causes that could result in wrong site surgeries. We begin with step 1, the outline. First we capture the what, in this case wrong site surgery. For the date, we can just write proactive because this is a proactive cause map and it's not associated with the specific incident. We want to capture any differences that could be more likely to result in wrong site surgeries. Specifically, emergency surgery can be more likely to result in wrong site surgery. Physical location is any location, and the work and task being done is any type of surgery. The goals can be impacted because of the potential for harm to patient. That's an impact to the patient safety goal. There's the potential for action against the employee, which impacts the employees. Wrong site surgery is a never event, which is an impact to the compliance goal. There's the potential for action against the facility, which is an impact to the organization goal. The actual cost associated with the action against the facility can vary, but many cases have been shown to have been settled for more than $500,000. The patient services goal is impacted because the surgery is performed on the wrong site. The cost of that varies by the type of surgery. The materials and labor goal is impacted because of the potential for the need for additional surgeries. Again, the cost associated with that is based on the type of surgery performed. Wrong site surgeries have been found to present a significant risk to healthcare facilities. Specifically, a study by the AHRQ has determined that the risk of wrong site surgery is about 1 in $100,000. The annual total for wrong site surgeries is unknown, so we can capture that as a question mark. Once we have captured the impacts to the goals, we can begin on step 2, our cause map. We begin with one of our impacted goals. In this case, the patient safety goal is impacted because of the potential for harm to the patient. We can continue to ask why questions to develop the cause and effect relationships that result in wrong site surgeries. In this case, the patient is potentially harmed because they have surgery performed on the wrong site. This occurs when a surgeon operates on the wrong site, and the surgical team does not stop the operation. Frequently, the surgical team does not stop the operation if there is not a timeout held prior to the surgery. Let's look at the causes that may result in a surgeon operating on the wrong site. The surgeon may operate on the wrong site because the surgeon incorrectly locates the site, possibly because of abnormal patient anatomy and or morbid obesity. The surgeon may believe that the wrong site is the right site. This may occur if the surgeon ignores paperwork and markings, if the paperwork is incorrect, or if there's no paperwork, or if the surgeon is unable to determine the site from the markings, or if the wrong site is marked. Let's look at why a surgeon would ignore paperwork or markings. Surgeon may ignore paperwork or markings if a physical exam gives conflicting results with the paperwork or markings, and or the surgeon chooses the surgical site based on incorrect radiography. This can occur if the radiograph is read backwards, if the radiograph is presented backwards, possibly because the radiograph is not marked with which side is which, or if the radiograph is marked incorrectly. A surgeon may be unable to determine the site from the markings if the site is or appears to be unmarked. This can occur if no markings are applied, or if the marking is in a location that is covered by surgical drapes, or if the markings are unclear. This can occur if more than one mark was made, such as marking the right and wrong site, and or if the markings are smeared during surgical preparation, or if the site uses inconsistent markings. The wrong site may be marked if the wrong site is identified during the marking process, or if markings are applied incorrectly during the marking process. The wrong site may be identified if the patient identifies the site incorrectly. This can occur if the patient has confusion over procedure or confusion over terminology that's used, such as numbering digits when referring to fingers. Or the patient may not be asked to identify the site. This is frequently the case during emergency surgery. Or the site may be determined incorrectly from the patient's chart. This can happen if the paperwork is incorrect and the site determination is not double-checked. We're going to look at double-checking and how that can reduce the risk of error. The process for surgical site marking can be identified as follows. The surgeon checks the chart, determines where to mark the site, and marks the site. If we use the error ratings given in the outline earlier, and we assume that a surgeon has an error rate of 1 in 100,000, which would result in wrong site surgeries at 1 in 100,000, then that gives us the error rate for this process. If, however, we take this process and add a step where a nurse or some other medical professional verifies the marking location, assuming that their error rate is similar at 1 in 100,000, that gives us an overall error rate of 1 in 10 billion. This is because when we have an independent check done in series with the first check, we can actually multiply the error rates together. This is now the chance that both the surgeon and the nurse would choose the wrong mark location. As some solutions, rather than allowing the patient to be confused over terminology, ask the patient to point to the surgery location. If the patient is available to identify the site, have them identify the surgical site. If they are not available, ask the family to identify the site. And ensure that there's a double check on the site determination, as we discussed in the previous process map. You can see some of the solutions that have been recommended to reduce the risk of wrong site surgeries here. Ensure that imaging data is reviewed by 2 members of the team. The surgeon should explain the surgery to the patient and then ask the patient to point out the location for surgery. The surgeon should mark the location of the surgery only using a facility-approved marking. The mark location and application should then be double-checked. The process map for surgical preparation can be identified as follows, based on the solutions in the previous slide. The imaging data is reviewed by 2 members of the team. This is relevant to solution 1 on our actions item table. Then the surgeon explains the procedure to the patient. That's step related to solution number 2. The patient points out the location for surgery. That's solution 3 and 4. The surgeon marks the surgical location, solution 5, 6, and 7. The mark location and application are then double checked, solution 8. And then an operating room briefing, also known as a timeout, should occur before the surgery. Extra care should be taken when laterality is an issue. Most wrong site surgeries are in fact wrong side surgeries. Now we'll look at a specific case study. In this case, surgery was performed on the wrong finger in October of 2009. One of the differences is that surgeries were performed on the same finger. This happened in a hospital in Rhode Island, and surgery was supposed to be performed on 2 different fingers. The patient safety goal was impacted because the patient was subjected to unnecessary surgery. Patient services was also impacted because of this unnecessary surgery. This is a never event. As a result of this incident, cameras were installed in the operating rooms, having an impact on the staff. The cost of this is unknown. The hospital was fined by the state health department $150,000, and there's the potential for additional surgeries, and in fact, the correct surgery was performed after this occurred. The cost of that was also unknown. In this specific case, the hospital involved had 5 wrong site surgeries in 3 years. We begin with one of the impacted goals. In this case, the patient safety goal is impacted because of unnecessary surgery. The compliance goal is impacted because this is a never event. And both of these occurred because of the operation on the wrong finger. In this case, the operation on the wrong finger occurred because the surgeon was unable to determine the surgical site from the markings. A nurse marked the wrist as opposed to the individual fingers, which were supposed to be surgically altered. This occurred because the nurse did not know where the incision would be made, and the nurse did not want to be reprimanded. The surgeon did not verify the mark or the site, and there was no timeout prior to surgery. The staff assumed that there was no need for a timeout, as they believed that the second procedure was being performed on the same finger. We can look at some of the things that went wrong with the process map that we developed before. In this case, the location was marked by a nurse rather than the surgeon who was performing the surgery. The nurse was unaware of the incision location. There was no double check of the mark made prior to surgery. There was no timeout before the second surgery, which was supposed to take place on a separate finger. Then, when the staff went back in and did the proper surgery, there was no timeout before the surgery was redone. I hope you've enjoyed our healthcare case study on wrong site surgeries, and that you can join us for one of our live webinars.